I would like to thank at the outset. I would like to thank Azim Misra and the Varanasi Herenek team for giving me this opportunity. So I've been asked to talk about case selection for transoral laser surgery in early glottic cancers.
This I can hear.
Vocal cord, as we all know, is a very unique site and functionally very important as well. Vocal cord is lined by an epithelium, which is stratified squamous epithelium. And the most common pathology in this region, as we all know, is squamous cell carcinoma. Anatomically, it's a very layered structure with each layer acting as a barrier for tumor spread. The vocal cord below the epithelium it has lamina propria. The superficial lamina propria is called as the Rinke space. Deep to the Rinke space, you have the intermediate and the deep lamina propria, which condenses to form an vocal ligament. Deep to which is the vocalis muscle, which is a part of the thyroarytenoid muscle. This has a very sparse lymphatics. As a result, vocal cord carcinomas, that is early T1, T2 cancers, the neck need not be addressed, and the treatment includes only treatment of the vocal cord cancers. The staging of the vocal cord cancers, that early vocal cord, is divided into T1 and T2. The T1 is again divided into T1A and T1B. T1A, meaning when the lesion is limited to the free edge of vocal cord without extension to the anterior commissure. T1B, when the lesion from the free edge of the vocal cord extend to the anterior commissure or crosses to the opposite side of the vocal cord. And T2, when there is extension to the supraglottis or the subglottis, but still retaining the vocal cord mobility. So treatment options available are the standard external beam radiotherapy, and the surgical options are the conservative open laryngeal surgery, as well as transoral laser microsurgery, the carbon dioxide laser being the preferred one. However, with better training, better understanding of this technique over the last 3 decades, transoral laser surgery is a preferred surgical option over conservative laryngeal surgery. So the decision of choosing transoral laser surgery over radiotherapy is dependent on the oncological control rates, the function preservation, both in terms of voice preservation as well as long-term functional larynx preservation, and of course, in Indian scenario, the cost of treatment. In terms of cost of treatment, the transoral laser surgery is very cost effective compared to that of radiotherapy. In terms of oncological outcomes, there have been numerous prospective as well as retrospective series, which shows that for a T1 vocal cord cancers, the local control rate is upwards of 90%, and laryngeal preservation rate is similarly more than 95%. For a T2, again, the local control is more than 80%, with the larynx preservation upwards of 85%. Similar to the radiotherapy technique, which again has excellent local control outcomes, more than 90%, with the larynx preservation rate upwards of 90% for a T1 glottic cancers. And even for the T2 glottic cancers, the radiotherapy has a reasonably good oncological outcomes, but the larynx preservation rate in the reported data suggests slightly inferior compared to that of laser surgery. Probably this is because of the selection bias for a transoral laser surgery. In terms of organ preservation rate, there are studies which shows that the organ preservation rate with transoral laser surgery is upwards of 90%. However, with radiotherapy, it's around 80%. The reason for this is whenever there is a recurrence or relapse following transoral laser surgery, there are still organ preserving options in the form of re-laser surgery, open conservative laryngeal surgery, or radiotherapy. However, when there is a radiotherapy failure, generally it ends up with a total laryngectomy. In terms of voice outcomes, again, when you do an vocal cord resections extending up to a type 3 cordectomy, where you have to remove a part of the vocalis at an extreme, the long-term voice outcomes are pretty good and equivalent to that of radiotherapy. However, when the extent of resections goes beyond the type 3, that is when it involves the complete vocal cord to the depth until the vocalis muscle or up to the thyroid perichondrium, or extension either supraglottic, subglottic, or a significant anterior commissure, the voice outcomes are inferior. So in transoral laser surgery, to get the best outcomes, we have to understand what are the bad cases. So what are the predictors for poor control for transoral laser surgery? That is, the most important thing is that when you take these patients for transoral laser surgery, put them on a suspension laryngoscopy, when you have a difficult laryngeal exposure, these are not ideal candidates. Or in terms of extent of the lesion, when there is a tumor which is extending to the anterior commissure, again, these are not ideal cases. The posterior extending lesions, which goes to involve the vocal process of the arytenoid or the arytenoid itself, or when it infiltrates the posterior paraglottic space, again, these are not the great cases to choose. So what is an ideal laryngeal exposure? Ideal laryngeal exposure, Professor Piazza and group have beautifully described the preoperative predictors in the form of a laryngo score, which later modified as a mini laryngo score, where they have classified that the classes of laryngeal exposure on suspension laryngoscopy under general anesthesia. When you when you place a laryngoscope and suspend them, if you're able to visualize the anterior commissure without needing any external pressure, then that is called a class 0 exposure, which is an ideal situation to go for transoral laser surgery if the site as well as the volume of the tumor suits the procedure. In certain situation, when there is slight difficulty in visualizing the anterior commissure, by withdrawing a scope a little bit up till the infrahead epiglottis, and then taking assistance from your colleague to give an external pressure so that you can visualize the anterior commissure. So the class 1 and the class 0 are the ideal laryngeal exposure situation to perform transoral laser surgery. However, in situations where there is difficulty in either visualizing the anterior commissure, or in certain situation, even having difficulty in visualizing the vocal cord, these are definitely not the cases to choose for curative intent transoral laser surgery. You need to do a biopsy and just prove the disease and better treat them with radiotherapy. In terms of site or the extent of the lesion, anterior commissure is one site which is a very difficult problem to treat, both in either of the treatment, whether it is radiotherapy or with laser surgery, because of the anatomical site itself, as well as the inability to focus the laser beam or fire the laser beam to get around the lesion. Hence, anterior commissure, you need to be very, very cautious in treating with transoral laser surgery. Additionally, whenever the lesion extends posteriorly, that is the lesion which involves the posterior paraglottic space with arytenoid fixation, infiltration into the preepiglottic space, or thyroid erosion, these again are not good candidates. There is a beautiful review article written by Professor Peretti and Piazza titled as "Reasonable Limit for Transoral Laser Surgery," which really kind of describes the what are the cases we need to do transoral laser surgery. An excellent article to read. So finally, the decision making for transoral laser surgery, like any other oncology scenario, is based on patient factors, disease factors, and the MDT. In the patient factors, especially in vocal cord, where voice is an important outcome and expectation, so these has to be discussed with the patient in making decision. And of course, in our scenario, as I discussed, the cost and the logistics also have to be factored in regards to the preoperative factors or the patient factors. In disease factors or the intraoperative factors, the suspension laryngoscopy exposure, the extent of the lesion, the involvement of the anterior commissure, as well as the volume, mostly the posterior extent, as well as the depth, that is the posterior paraglottic space and the subglottic extension. And of course, discuss in the MDT and give the option to the patient and make a combined decision uh, of choosing one over the other, because both have reasonably good outcomes. So my philosophy is to all patients with a T1 lesion, that is whenever the lesion is in the free edge of the vocal cord, or lesions just extending to the anterior commissure without, which are not very bulky, no subglottic extension, no significant posterior paraglottic extension, are are the candidates where I would push for a transoral laser surgery. However, on flexible endoscopy or on intraoperative evaluation, whenever there is a bulky lesion going to the anterior commissure with subglottic extension, these are the cases which I would do a biopsy and refer to them for a radiotherapy. So I shall just discuss few cases. So the lesion in the free edge of the vocal cord, which can be looking like look like uh, a superficial leukoplakic kind of a lesion or a Rinke's edema kind of a lesion, where I straight away discussed with the patient and considered for a type 2 cordectomy with the excision of the entire lesion with a millimeter margin all around, the depth of the resection being the subligamental, that is the vocalis muscle, was preserved. So laser being a very precise cutting tool with a focused beam, there is minimal collateral damage, minimal charring. As a result, the functional recovery is excellent. These patients are done as daycare procedure without a need of any overnight stay in the hospital. As a result, the acceptance as well as the recovery of these are very good. So this is the type 2 cordectomy being performed. Post-resection, it's very important to orient these specimens properly. So we need to have a proper dialogue with the pathologist in terms of the understanding the pathology as well as margin, so that we get the right pathological analysis. So situations like this, where is a lesion in the mid-vocal cord, where your ENT colleague has done a biopsy and the biopsy has turned out to be a squamous cell carcinoma, is pretty common. So in this kind of situation, we need to understand that based on certain retrospective series, it suggests that when you do a laser emulscopy biopsy and then do a re-laser excision, 30 to 40% of them won't have tumor. As a result, it's very important to counsel these patients for transoral laser surgery, because unnecessarily you will be irradiating 30% of patients without having tumor based on this data. So T1A lesion, which is limited to the free edge of the vocal cord, it is better to consider for a upfront laser cordectomy or an excision biopsy, and that is how probably it has to be treated. So lesions which are involving the mid third of the vocal cord without significant extension to the ventricle, that is, this is a T1A lesion, slightly bulky lesion. We always do a telescopic evaluation with the 0 and 30-degree endoscope to ascertain the subglottic extension, the anterior commissure extension, as well as the ventricular extension. And also, you use a blunt suction tip or a blunt instrument to palpate the paraglottic space as well as arytenoid. And in certain situation, you can also do a saline injection to ascertain whether the ligament is involved or not. Thereby, you can plan your depth of resection. So in this case, it was a lesion which was limited to the mid third of the vocal cord without significant anterior commissure. It was a class 1 exposure where I needed a support from my colleague to get the anterior pressure. Always you need to keep a wet neuropathy to cover the endotracheal tube to prevent any inadvertent damage to the cuff of the endotracheal tube or an airway fire, possible theoretical airway fire. And then we need to go around and excise these lesions. Again, as I told, in these post-excision, you need to orient them properly So we use a pictorial represented paraffin block to pin these specimens, ink it, and then pin it with pin the needles, and then we take it to the pathologist, and we usually do a frozen section to analyze the margins. However, it's a debatable topic. We as a routine do a frozen section to make sure we have got the margins all around, and then once we get the pathology report with regards to the margin, then we extubate these patients. Post resection, sometimes there may be a bit of charring in the operated bed. So we use wet neuropathy to remove the carbon particles to reduce the granulation formation, thereby have a better healing and better voice outcomes. Certain situations where patient had vocal cord lesions in the anterior commissure, had multiple biopsies which had come at leukoplakia, uh, sorry, leukoplakia. So this is the case in point. Was an 80-year-old male patient who had a lesion in the vocal cord, who had multiple two microlaryngoscopy biopsies done over the 2 years time. The reports were severe dysplasia. He had come to us for an opinion. So as I told, we always counsel these patients and take up for an examination under anesthesia. Under examination and under anesthesia, we can see that the anterior synechial formation and the lesion being free from the ventricle, no subglottic extension, no significant anterior commissure extension. And these are the cases we straight away go in for a transoral laser assisted excision biopsies. So this kind of resection in the anterior part, we have to go up right up to the perichondrium. And when you do this kind of slightly extensive resection, there is a chance of granulation formation post-operatively, which needs to be discussed with the patient on follow-up. So when you do this kind of an extensive resection, we always counsel the patient for a second look operation done at about 3 to 4 months if the postoperative follow-up shows a granulation tissue formation. So this patient at 2 to 3 months had granulation tissue formation. Uh, However, the second look operation in that showed no disease. So even these patients, when you follow up them on a long term, when you do this extensive resection as well, they heal very beautifully without much of a phonatory gap. And you can appreciate the same patient at about 6 months that we have done an extensive resection, but it has healed beautifully. And the voice outcome of the same patient.
When the sunlight strikes raindrops in the air, they act as a prism and form a rainbow.
So despite such an extensive resection, the voice outcomes are reasonably good. So it's very important that during the operation, we have to make sure that end of the operation, we remove the carbon particles and then follow up, and in certain extensive resection, follow them up with the second look operation. So T1B is a situation. It's a bit of controversy whether these are ideally treated with transoral laser surgery or radiotherapy. However, if the patient has a good exposure under general anesthesia on suspension laryngoscopy, and if the patient is willing to compromise on the voice results, probably again it needs to be discussed with the patient and then decide to go for transoral laser surgery. So in this case, patient was a laborer coming from UP to us in Bangalore. So he opted for transoral laser surgery, slightly extensive resection. Because he had a good exposure, we could go right up to the thyroid perichondrium, opposite vocal cord. We got a good margin all around. And the voice outcomes of the same patient at about 3 months, it's not very great, but reasonable to have a conversational voice, reasonably good conversational voice. So again, these are not ideal cases. However, if the patient's voice expectations are he's willing to compromise on the voice outcomes, probably laser is an option to be considered. T1A T1A lesions were bulky anterior commissure lesion, but no significant subglottic extension. Again, we gave the option for transoral laser surgery. This patient opted for transoral laser surgery. There's a bit of subglottic extension. However, the exposure, it was a class 0 exposure. So we went ahead and performed the transoral laser surgery. So you can see that the anterior commissure has been excised right up to the cartilage, down good subglottic margin as well. Again, this patient is about 1.5 years post surgery, and he's doing reasonably well. I don't have his voice recording, so he's from a slightly far away place, so he didn't come for follow-up, and he's following up with the ENT colleague. So when you do this extensive resection, you do a transtumoral resection, so you break it into two pieces. And then it's very important again to orient it and analyze these tissue properly, and generally these extensive resection need to be followed up with a second look operation. So certain very extensive lesion. This was
Hello everyone. My name is Dr. Akshay.
sorry. So this was a lesion, varicose lesion involving the entire vent of the vocal cord. So again, in this patient, this is again not an ideal case scenario. However, in view of the varicose looking lesion, we counseled the patient, explained about the voice outcomes and a possible functional problem, and took him up for the transoral laser surgery with curative intent. So in this kind of extensive resection, it's better to do a transtumoral resection, first using laser to break it into blocks, that is to ascertain the depth of the tumor-free margin. So you can see that when a laser cuts on this tumor region, there is carbonization. However, when you have a carbon-free tissue area, that means you are well away from the tumor. That is further confirmed by a frozen section. So the tumor was extending up to the vocal ligament. The part of the vocalis muscle was resected in this. So initial part involved resection of the anterior part of the lesion. Once we got the ascertain the depth, which is tumor free, the part of the vocalis muscle was removed. And once we got the tumor free region, we went around the tumor right up to the anterior commissure, and got the subglottic anterior commissure margin. And then once we finish the anterior part, we push the endotracheal tube forward by placing the laryngoscope and then suspending it, and then go around and excise these lesions. So I have no much experience in doing extensive posterior resection. I think this was my only case where I had for malignancy, where I had to remove the vocal process of the arytenoid, as well as the part of the arytenoid. And this patient is doing reasonably well. This patient didn't have any functional problem for swallowing, but the voice was a little bit hoarse, and she's undergoing speech therapy. So again, orientation with inking and proper pinning those specimens and orienting this for proper analysis, and removing those carbon particles for better healing. So finally, to conclude, I would summarize by telling that for a TIS, the carcinoma in situ lesions of the vocal cord, transoral laser surgery is a preferred option. For a T1A, that is lesion limited to the free edge of the vocal cord, if there is a good exposure on suspension laryngoscopy, again, transoral laser surgery is preferred. For a lesion which is extending to the anterior commissure, that is T1B lesion, the lesions which are not bulky, if we have a discussion with the patient and the family, and if he doesn't have very high expectation with the voice post treatment, then again laser can be a preferred option to be given to the patient. However, when there is a anterior commissure region which is bulky with subglottic extension, that is definitely not at all a candidate to choose for transoral laser surgery. For a T2 lesion, when there is no anterior commissure, good exposure, transoral laser surgery can be an option to give to the patient if again patient is willing to compromise on these voice outcomes. T2 lesion with anterior commissure extension, again RT is preferred and not good cases for transoral laser surgery. So thank you. Thanks for the opportunity. So if you have any questions, I can take.
Thank you, Dr. Akshay. It was a very simple, elaborate, and descriptive presentation. Thank you so much for the presentation on such a difficult topic. Now we would move on to the case presentation. The topic of the case presentation is early laryngeal carcinoma. I would like to invite our esteemed panel. As chairperson, we have Dr. Anup Raj. He is the Professor of Excellence and ex-HOD, ENT and Head and Neck Surgery, Maulana Azhar Medical College, New Delhi. Then I would like to invite Dr. Deepa Nair. She is a Professor at Head and Neck Surgery, Tata Memorial Hospital, Mumbai. Dr. Krishna Kumar Thankappan. He is Professor Head and Neck Surgery at Amrita Institute, Kochi. And Dr. Prashant Pawar. He is a Senior Consultant Head and Neck Surgery at Fortis, Mulund. All our esteemed examiners, are you available online? Is everyone logged in?
Yes, yes.
Yes, I'm there, Ravi.
Sure, thank you. So, and now I would like to invite Dr. Karthik Rao. He is a resident head and neck surgery from AIIMS Raipur. He'll be presenting the case on early laryngeal cancer. Dr. Karthik.
Good evening, sir. Good evening, ma'am. Good evening, everyone. If you guys permit, may I present the case?
Please start, Karthik.
Yes, ma'am. Yeah, so I'm presenting a case of a 62-year-old gentleman who is resident of Raipur, who was working at a cotton mill. So he has a good performance status, ECOG grade of 0. He doesn't have any comorbidities. He also is a habitual tobacco chewer and a smoker, coming up to around 15 pack years. He presented to us with hoarseness of voice since 3 months. So the hoarseness was insidious in onset, which was gradually progressive. So it was associated with difficulty in speaking for a longer time. He says he was able to speak only a few sentences at a time. So he doesn't give any history of difficulty in breathing, no history of any cough or hemoptysis, no history of any difficulty in swallowing, no history of any foreign body sensation in the throat, no history of any cough on swallowing solids or liquids, no history of repeated shouting or screaming, no history of recurrent chest infection, no history of any swelling in the neck while talking, no history of any trauma to the neck. He doesn't give any other significant ENT complaints, and patient also doesn't have any significant past history. So moving on to personal history, patient is, it is 15 pack years. Personal history, patient is a reformed cigarette smoker of around 15 pack years. Patient is also an occasional alcohol consumer. So on general physical examination, patient is conscious, very well oriented, pulse rate of around 70 beats per minute, blood pressure of 110/70, respiratory rate of 14, saturation of 98% on room air, no stridor. Systemic examination is well within normal limits.
Karthik, can we interrupt here?
Sure, sir. Sure. Please, sir.
Right. So you have, can you summarize your history?
Yes, sir. So it's a middle-aged, a middle-aged man who has come with history of hoarseness since 3 months without any comorbidities. He has good performance status. So other than that, he doesn't have any other significant complaints.
He was the savior of us in OPD.
Right. So
Yes, sir.
you said he's a smoker, right?
Yes, sir.
What's a smoker?
Yes, sir. Tobacco. He was a cigarette smoker, sir.
Cigarette smoker.
Yes, sir. Cigarette smoker, and he has stopped smoking since 3 months when since his complaint started. So he stopped. Before that, he had smoked for 15 pack years cumulatively.
Dr. Karthik, for the interest of audience, can you explain what
Yes,
do you
sir.
mean by pack years?
Sir, pack years is number of pack. So one pack of cigarette contains around 20 cigarettes. So cumulatively, the number of it is the number of packs and number of years which is smoked. So it comes up to around number of cigarettes divided by 20 times this one. So it comes up to 15 pack years. So more than 10 to 15 pack years would be a significant history if the patient smokes.
Okay.
Right.
And,
And yeah, proceed.
You were mentioning that he was smoking cigarette. Does it
Yes, sir.
matter? Does it matter what kind of smoking he was doing, and how
Definitely,
does it
sir.
matter?
Sir, actually, the type of smoking also matters because it is the type of tobacco which is also very important. So it is the white tobacco. The tobacco. So the way there are different types of smoking which everyone does. I mean, one, it can be because of tobacco smoke. It can be because of marijuana, and recently there has been a trend of using e-cigarettes also. So the tobacco smoke contains more amount of carcinogens, and it does matter, sir. And with cigarette smoke, there is also presence of filter. The amount of compared to a BD, so the amount of carcinogens in a BD would be higher compared to a tobacco. So it does matter, sir, what smoking he does. And recently there has been a study which also says that marijuana use and e-cigarette also has a higher potency of development of cancers of the upper aerodigestive tract.
Can you tell how many fold there's an increase in incidence of laryngeal cancer because of smoking?
Sorry, sir, I was not able to get it, sir.
Can you tell how many times does the risk of laryngeal cancer increase because of smoking? Like the
Sir,
relative risk.
Sir, it is. Hello, sir.
I am Dr. Anupraj. I just wanted to ask only one question. Can you just explain?
Yes,
just explain me. You said in your history, patients become. He's not able to speak more than few words.
Yes, sir.
And in the same case, you also said the lung functions are normal, chest is
Yes, sir.
normal. Can you explain me why only few words?
Yes, sir.
What
Sir, lung function per se, as per history, I mean, patient has been smoking for a very long time, at least from last 20 years. Patient seems to have increase in maximum reduction in maximum phonation time. That is, patient is having symptoms of vocal fatigue. And based on initial evaluation and history, what I've asked for the patient doesn't give any significant history which is suggestive of chronic respiratory, chronic obstructive pulmonary disorders. Patient does not give.
What was the phonation time? You have not mentioned.
Sir, based on the history, he said that he was able to speak only for a few sentences at a time. So I was not able to pinpoint exactly how much time he was able to speak. He said he had to stop for a while after he spoke a few sentences. So,
what is a normal time?
So normal maximum phonation time would be around 2 to 3 minutes, if I'm not mistaken. I'll have to look once again, sir.
Not minutes, in seconds.
I think
how many
second.
Have you tried to, what is the normal phonation time of a normal person?
Sir, I think it must be around 25 to 30 seconds, if I'm not mistaken.
No. Normal phonation times start from 16 seconds. Then onwards, maybe some few people, even 16 seconds is a normal phonation time.
Okay,
that is
sir.
it. And that too, if you have the phonation time is not reduced, how you can say the words? He is not able to speak few. He is only able to speak few words, unless until their chest involvement is there.
Yes, sir. Okay, sir.
And now we go on. We'll see the examination. Let me see how big growth is there.
Sure, sir.
Continue, please continue.
Yes, sir. So shall I move on to examination, local examination?
I think just before that, no? Can you
Yes,
just
sir.
explain all the questions that you asked, the negative history?
Sure, sir. Sure.
What were your reasons for asking these negative?
Yes,
Yes.
sir. I would be glad. Yes, sir. So number one, a patient. So I've asked about history of difficulty in breathing. So the reason why I've asked for history of difficulty in breathing is I wanted to, by history, I wanted to know if patient is having any airway obstruction or patient is having any narrowing of supraglottic or glottic airway. So next one is history of cough with hemoptysis. So so if the tumor is very fragile, so patient can have hemoptysis because of excessive coughing and also any other upper aerodigestive tract tumors can also lead to hemoptysis. No history of difficulty in swallowing. Supraglottic tumors or any piriform fossa tumors infiltrating into the piriform sinus and post-cricoid region can lead to patient having difficulty in swallowing. History of foreign body sensation in the throat is mainly because of the irritation of the pharyngeal plexus and glossopharyngeal nerve. Patient tends to have irritation, and that is the reason patient might present with foreign body sensation in the throat. So history of cough on swallowing liquids or solids. So I've tried to ask the history of symptoms suggestive of aspiration by asking this leading question: if the patient is able to swallow certain glottic tumors as well as hypopharyngeal and supraglottic tumor can lead to a patient having cough on swallowing, that is impairment in laryngeal function mainly because of aspiration. So I asked history of repeated shouting and screaming because certain patients who are used to repeated shouting and screaming in their work or in their home for a long time, they can have some benign vocal cord nodule. So I wanted to ask if preemptively patient has this issue. So I wanted to ask recurrent chest infection mainly because of one, he's a smoker, and second, I wanted to know if there is any silent aspiration if patient is having recurrent chest infection or bouts of chest infection in the previous history. So next would be swelling in the neck while talking. So I wanted to rule out any laryngocele in the patient that might present as a swelling when the patient is in certain cases of laryngocele, the swelling may increase or decrease while the patient is talking. So no history of trauma to neck. Trauma directly onto the larynx might also lead to dislocation of cricoretinoid joint, and patient may have a difficulty in talking, or he may have hoarseness of voice. So, and I have asked for other significant complaints pertaining to this. So these were the points why I have taken this negative history.
So Karthik, Deepa here.
Yes, ma'am. Yes, ma'am.
At the end of your history taking, what is the differential diagnosis if you had to give one?
Ma'am, he's a 62-year-old gentleman. He's a known cigarette smoker with 15 pack year. He's a middle-aged man. So good comorbidities, no history which is suggestive of a large growth within the glottis. So I can narrow it down to, and he is also a worker in mill. So I would like to have a differential diagnosis of vocal cord pathology. Either it can be a benign or malignant. I would like to correlate these findings with my clinical examination.
Right. So with only a history of hoarseness and no other history, the best
Yes, ma'am.
diagnosis you can give is a vocal cord pathology. Now,
Yes,
can you classify the possible common causes, don't give me rare causes, of vocal
Sure,
cord
ma'am.
pathologies in a 62-year-old male?
Yes, ma'am. So one, it could be number one, vocal cord nodule. It could be a vocal cord cyst. It could be a hemorrhagic vocal cord cyst. It could be because of if we had any sudden, there can be bleeding varices within the vocal cord. It could be sulcus vocalis. Or coming to malignant pathology, or it could be even a small dermoid of vocal retention cyst within the vocal cord. Also, it could be a malignancy and It could be a display starting ranging from dysplasia all the way up to malignancy.
Why aren't you thinking in terms of benign lesions like laryngeal tuberculosis or malignancy of the mediastinum, which is causing a recurrent laryngeal nerve palsy?
Definitely, it could be a possible cause for this particular setting, ma'am. Tuberculosis being one of the most common causes of.
Karthik, you have already ruled out the tuberculosis. You said chest is normal.
Yes, sir. On physical examination, a patient with tuberculosis can have, I mean, with a chronic tuberculosis patient, yes, sir, definitely. We would like to do further tests to completely rule out tuberculosis.
Still, I am not able to appreciate your one finding that patient getting a tiredness, get tired after speaking few words. I couldn't understand what history, unless until you will give me the phonation time, I will not able to come to the conclusion.
Yes, sir. So I was unable to get the exact phonation time. So he said that he was only able to speak a few sentences at a time.
That phonation time cannot be judged.
Yes, sir. Sure, sir.
It for a physical examination, what local examination you have done?
Yes, sir. Continuing on to the local examination, patient larynx appears to be in normal position, no laryngeal widening, trachea appears to be in central, there is no loss of laryngeal crepitus, there is no palpable thyroid mass, no palpable neck nodes. So his mouth opening is adequate, patient is able to extend as well as flex neck well. So there is no mandible, he is able to open his mouth well, no deviation of mandible. Patient has normal tongue. So there is no presence of mandibular or palatine tori. Base of tongue is normal and supple on palpation. Bilateral tonsil appears to be normal. Posterior pharyngeal wall is clear. So patient has a Malampati class 2, wherein tonsil and bilateral tonsil and part of posterior pharyngeal wall and our uvula is also seen. So on flexible laryngoscopic examination.
Karthik, why did you think of telling us the Malampati class in this patient?
Sir, Malampati class, basically I wanted to see what the exposure of this patient is. Malampati is also considered as, so considering this to be a vocal cord pathology, so I wanted to know what would be my difficulty in doing a direct laryngoscopy in this particular patient. So that's why I have written Malampati score.
Okay, all right, good, go ahead.
So can I move on to flexible laryngoscopy, sir?
Sure.
So on flexible laryngoscopy, so I've rotated the video to show it as a direct laryngoscopy. So the cord on our left is left of the patient and cord on the right is right of the patient. So here I'm able to see a reddish ulceroproliferative growth, which is seen on the left true vocal cord in the anterior 2/3 parts. So anteriorly, it is just reaching up to the anterior commissure. Posteriorly, it is just coming onto the posterior commissure, but not involved. So the right cord appears grossly normal and bilateral cord appears to be normal. So this is my flexible laryngoscopic examination.
So you will just tell the glottic findings?
No, sir, definitely. Rest all the other larynx was normal in examination. So base of tongue vallicula. So I have come to detailed examination after we have done a direct laryngoscopic examination, but I just wanted to highlight the positive points here. But while explaining it in history, I would like to tell everything in starting all the way from base of tongue vallicula, then lingual surface of epiglottis, laryngeal surface of epiglottis, pharyngoepiglottic fold, array epiglottic fold, arytenoids, interarytenoid area, piriform sinus, and false vocal cord, true vocal cord, and part of subglottic and tracheal area, what we will be able to see, and posterior pharyngeal wall, of course.
Right. What is marginal zone?
So marginal zone is a zone which is transitional area which is found between the glottic and medial surface of medial wall of the hypopharynx. So the tumors, this area is called as marginal zone.
Why? What could be the reason that it is called as a marginal zone?
Sir, it is this exact name I really don't know, sir. Like marginal zone cancers tend to have uh, tend to be more aggressive, and they tend to have tend to have lymph nodal metastasis, and they tend to do very bad, poorly. Yes, sir.
Karthik, your answer to the question, why is it called a marginal zone?
So
You can say I don't know.
yes, sir, I don't know.
Right. So marginal zone is a margin between the larynx and the hypopharynx.
Correct,
Okay.
sir. Yes, definitely. Yes.
That's why it's called as a marginal zone.
Okay. Yes, sir.
Right. What is a line that separates a glottis from supraglottis?
Sir, glottis from supraglottis is defined as by a plane, horizontal plane, which is passing through the upper point of plane passing through the saccule. So that plane, so that is the line which separates the supraglottis from glottis. From the ventricle. So the line passing, so horizontal plane passing through the apex of ventricle divides the lower part of that plane as glottis, and then above it would be supraglottis.
Okay, now you have to read the.
Yes, sir. 1 centimeter below that plane would be glottis.
Okay. I'll probably agree to that. But if you read AJC, there is a subtle difference. Probably you can refer to that.
Sure, sir.
Right, continue.
Yes, sir. So, sir, we had also done a direct laryngoscopy. If you permit me, I'll go to that, sir.
Sure.
So we had done a direct laryngoscopic evaluation along with biopsy for this patient. So in this patient, starting from superior to inferior. So while inserting the scope, the glottic exposure were based on modified Cormack-Lahane was grade 1. So base of tongue, vallicular epiglottis, bilateral arytenoid, bilateral AE folds, bilateral pyriform sinus was normal. So there was a presence of ulceroproliferative growth, which was seen on the, sorry, it is left, just please read it as left. So seen on the left anterior 2/3, anteriorly reaching up to anterior commission. Posteriorly, it is just anterior to left vocal process. The right vocal cord is normal. So we had also used a 0° and 30° Hopkins rigid endoscopy to evaluate the subglottic extension as well as the extension into ventricles. So there was no obvious subglottic extension. Bilateral false cords were were normal. Bilateral ventricles were normal. Bilateral arytenoids were normal. Bilateral pyriform sinus were normal. Interarytenoid, retroarytenoid, postcricoid, and cricopharyngeal introitus were normal. So we had also done a palpation by using gentle palpation with suction. So with suction, I was able to look at the arytenoid mobility, and both the arytenoids were mobile. The same we were able to corroborate with the flexible findings. So there was no fixation of cricoarytenoid joint, no gross paraglottic extension. So I was just able to palpate the paraglottic space just adjacent to our true vocal cord. So we were not able to find any induration over there. And also, while gently touching the tumor, the lesion bled on touch. So we also used infiltration tests to determine the depth of the tumor. So although this is just a whether we will what kind of surgery we might be able to do. So we just infiltrated in the subepithelial region, and we were able to see the lesion lift up easily after infiltration with saline. So we had also did just before prior to extubation, we had done a airway assessment with Hopkins 0° endoscope. So the trachea all the way up to carina was normal. So we had taken a biopsy, and it had come as well differentiated squamous cell cancer.
Oh, you have presented the findings very well, but I have a basic question. You are a what do you do? I mean, you're a candidate appearing for exam,
Yes,
right?
sir. No, sir. No, sir. No, sir. I'm actually second year MCH. Sir.
Second year MCH. So, yeah, probably. So,
Yes,
so I'm not sure whether in an when a patient is given to you in an exam.
Yes, sir. So
will you be able to
I understand.
give all these findings like
No, sir.
BL
No,
and
no.
biopsy?
Definitely no, sir. No, definitely it will be told to us like what DL scopy findings would be, and for the completion's sake, I have just presented, and for
Probably you would
discussion
have
sake, I presented.
presented only the clinical examination and scopy examination findings. I mean,
Yes, sir.
if you are trying to learn and try to present a case like that, just a comment, that's all.
Sure,
But
sir.
you have presented the
Sure,
findings
sir.
very well.
Thank you, sir.
Deepa, go ahead, please.
So Karthik, I think the point is very valid. Would you really need to do this elaborate DL-scopic examination for a patient who has got a very mobile cord and you've done a very good flexible examination? You can biopsy the same thing in the OPD.
Yes, ma'am.
Why do you need to do a DL-scopy for this patient?
Ma'am, actually, I wanted to do a proper DL scopic examination to look for one to take a biopsy for this patient, and also thoroughly examine the upper aerodigestive tract if there is any presence of any other lesions within the larynx or this one, ma'am. Because even with the flexible laryngoscope, there are certain areas where I won't be able to see very well. So it is especially in the postcricoid area and in the ventricle, so I won't be able to assess it very well. And also the subglottic extension, we won't be able to appreciate so well in the flexible scope. So that's the reason why we have done this one.
Most importantly, you would want to see whether you are able to suspend well.
Correct.
So that whenever later you're going to plan a laser procedure, then you already have the information.
Correct.
Would you want to add something done on OPD basis, or when you
Ma'am, I'm extremely sorry. The voice broke. I was unable to hear.
Yes, ma'am, your voice is breaking.
Sorry, can you hear me now?
Yes, ma'am, better.
Yeah, so my question was, would you like to add any adjuncts to this examination to improve your diagnostic capability?
Yes, ma'am. So there are newer imaging modalities where we would be, if available at an institute, we could use a narrow band imaging to look at the areas. In this particular patient, we'll be able to properly identify where all there is areas of concerns, areas of suspicion. So we can use narrow band imaging along with this. And also there is optical coherence tomography that also can be used if available. That would help us identify other suspicious area, and if the lesion were to be not so obvious, so it would help us identify the extent of the lesion in that scenario. And also narrowband imaging has shown its ability to identify areas of suspicion in cases where a patient has already received therapy.
Karthik, you said
Yes, sir.
you did direct laryngoscopic examination after your flexible examination.
Yes, sir. Yes, sir.
I would say probably you should have gone for some imaging.
Yes, sir.
Agree with me or will you disagree with me?
Definitely agreed, sir. Before going on, so I'll be coming with so we had done a CECT. So
where will you place? Question is, where
yes,
will you place this cross-sectional
yes,
imaging? Sir. Will you
yes,
place
sir.
it before your scopy or after
Definitely
before your biopsy or
100%. 100% you are right, sir. We'll place it before our scopy, sir. We would like to, sir, first we would like to understand whether what is the lesion which is present in the patient. Then only we would like to subject that patient to understand the anatomy properly. Just before taking the patient into OT, we should know exactly where the pathology is and what the extent of the disease is. So we'll have a clear idea of what we are dealing with. And also, not in this particular scenario, but in any other patients with, say, for example, hypopharyngeal malignancies. So if we
don't go to hypopharynx
sure,
now. Stay with the larynx now.
Yes,
so
sir.
you would have done the cross-sectional CT scan before the DLScopy. Agreed, right?
Yes, sir.
So
yes,
what
sir,
are the
definitely.
indications of a cross-sectional imaging in this patient?
Sir, in this patient is a chronic tobacco smoker. So he has a 15-pack year history. So he has history of hoarseness, and on flexible laryngoscopy, patient has a suspicious lesion on the left vocal cord. So now we would like to assess what is the extent of the what is the reason for what is the extent of the growth or suspicious lesion in the left vocal cord, and also to assess, as he's a alcohol as well as tobacco smoker, so patient can have other upper aerodigestive tract lesions. So I wanted to evaluate the extent of the disease, presence of
When
other
you
upper
say
aerodigestive.
extent, what do you mean exactly? What are
Sir,
you concerned?
yes, sir. Number one, I would like to look at whether anterior commissure is involved or not. Second, I would like to know if there is any involvement of paraglottic space, whether there is any gross subglottic erosion, or whether there is any erosion of inner cortex of thyroid cartilage, and also presence of lymphadenopathy.
Right. What is the significance of paraglottic extension?
Sir, paraglottic extension from a glottic tumor will stage the tumor from, if it is involving only the lateral cord, it may extend from T1 all the way up to T3. So so stage will increase and the treatment modality will change.
Okay. Prashant, please.
Karthik, what is the role of
Yes,
an MRI in this case?
Ma'am, MRI here would be a problem solving tool. So here MRI will be able to tell us whether, so if there is any slight extension into paraglottic space where we are not able to completely appreciate on a CT scan. So MRI larynx will be able to tell us properly, if tell us with certainty that there is involvement of paraglottic space or not. And also if the tumor, if it is present in the anterior commissure, it will be able to tell us whether the anterior commissure is completely involved with or if the inner cortex of thyroid lamina is involved. So here it will act as a problem solving tool.
Do you really think for a T1 glottic cancer, which you've done a endoscopy, an MRI is indicated?
In this case, no, ma'am. MRI is not indicated in this particular setting.
Yeah, so it's not for this setting, but it's for maybe a T3 lesion where you're
Definitely.
suspecting a difference between a T2 or a T3 or a T3 versus a T4.
Yes, ma'am.
Okay. What are the advantages? You've said some advantages of the MRI. What are the disadvantages compared to a cross-sectional CT scan?
Ma'am, in CT scan, number one, the acquisition time of CT scan can be done within minutes. Second, the CT scan will be able to tell us with thin cuts all the way up to 1 to 2 millimeter cuts can be obtained with CT scan. A thin slice CT can be done. Next one, dynamicity. We can do dynamic procedures while doing a CT scan. So we can ask we can take CT cut while the patient is saying certain words E, or if when the patient is deep breathing, or cuts can be taken even when the patient is doing Valsalva. Unfortunately, the acquisition time for MRI takes, it depends on type of MRI which we are doing. So there will be, so the time is increased. It can range from 20 minutes all the way up to 45 minutes. So that will be an issue. Second one, the larynx is a dynamic organ. It moves with respiration. So there will be presence of artifacts when we do MRI scan. So, and next one, the slice, the MRI will not be able to give us ultra thin slice, and it is subject to motion artifacts in this patient, in this particular setting.
Any role for PET scan?
In this case, ma'am?
Yes.
Ma'am, in this case, I wouldn't think doing a PET scan would be an ideal option. But in a patient who has already been treated for this particular setting with radiation, so in that particular patient, I would like to go ahead and do a PET scan to look for any other tumors within the upper aerodigestive tract. Although it is CECT might be sufficing, but it could be indicated in that setting if we are talking about T1 larynx and recurrence.
So for a T1, T2 early glottic cancer, a screening CT scan of the thorax may be enough. You
Yes,
have
ma'am.
to remember that this patient is a smoker. So
Yes,
rather
ma'am.
than
Definitely.
extent of the disease per se, the PET will, I mean, the scan is for looking for second primary. What's the
Definitely.
incidence of second primary cancers for patients who have glottic lesions?
Exactly for glottic lesion, I think it ranges from 10 to 15%, if I'm not mistaken.
And which is the most common second primary?
Most common second primary is lung, ma'am.
Okay, so because of smokers, their most common second primary is in the lung.
Yes, ma'am.
If the others agree, I think we are going to be short of time. So let's move on to management.
Yes.
So based on chest X-ray is clear and doesn't show any M5 status changes. So his blood investigations were well within normal limits. So I would like to stage this patient at CT1A N0M0 carcinoma of left true vocal cord.
Okay.
Yes.
How will you proceed?
So for this particular patient, I would like to discuss the treatment options with the patient. So first, I would like to discuss regarding surgery. Next, I would like to talk to him about radiation. So I would like to tell him before going to surgery, the surgical procedure would lead to impairment of his voice for first few months, but it may improve later after 3 to 4 months and may come back to his previous voice by around 6 to 8 months on a long-term basis. If the patient is going to, and the surgery is going to
Karthik,
be,
I'm not sure what surgery are you talking about. You didn't tell us what surgery, what procedure.
yes, sir. So number one, if
And
for
what
this
is your
particular,
intent of treatment?
sir, my number one intent of treatment.
Hello.
Yes, sir. Yes, sir.
Have you given the classification, TNM classification, where you are putting the patient?
Sir, he's a T1A stage, sir. T1A N0M0 carcinoma of left vocal cord. Stage 1. So coming to intent. Hello. Sir, I'm unable to hear your voice is breaking.
Karthik sir was asking what exactly kind of surgery are you proposing for this?
Yes, sir. Sir, number one, coming to intent of therapy. So the intent of treatment would be curative. So first, I would like, if I'm going to go ahead with surgery, so I would like, based on his clinical examination, based on his direct laryngoscopy, the exposure to larynx is good. And if patient, after counseling, if patient agrees for surgery, so we can plan the patient for transoral laser microsurgery by doing a type 1 cordectomy.
Can you tell us the types of cordectomy?
Yes, sir. So types of cordectomy is given by European Laryngeal Society. So initially it had given 5 types of cordectomy. In 2008, they had revised to include the 6th type.
Hello.
Karthik, we are not able to hear you. Karthik. Karthik.
Who is moderating the session? What's happening?
Dr. Ravi Shankar.
Hello.
I think Karthik has logged out. He's logged in
logged
again.
off. He's just trying to log in back. He's coming back. Yeah. Dr. Karthik, are you there? I'll just call him up.
I think he has logged out.
Trying to log back.
Maybe in the meantime, if there are any questions in the audience.
Deepa madam, there is one question about pre-op infiltration. If you can elaborate on that.
So I think Akshay has already addressed that in the chat box. So preoperative infiltration is a good way of hydrodissection basically to check whether the lesion is firmly adherent to the underlying beyond the ligament into the vocalis muscle, or it's very superficial on the epithelium. It's useful only for early lesions, mainly for carcinomas in situ or very early vocal cord lesions. If there's infiltration, if it's going already deep into the paraglottis, it's not of much benefit to these patients. So basically, the infiltration lifts up the lamina propria away from the vocalis and gives you a better plane of dissection and helps you to prevent any unnecessary resection of the vocalis. So you can really limit your resection to a type 1 or a type 2 cordectomy.
Just one question, like Dr. Akshay had also mentioned, that in such a lesion, you can actually go and plan after you've done a good flexible examination and you reasonably are sure that you'll be able to treat this patient well with a translaser microsurgery. Would you recommend going ahead with the translational microsurgery, or would you still want to do a biopsy first? And many times there are also insurance related issues, because when we tell it as a diagnostic procedure, most of the times the claims are rejected. So many of the surgeons actually plan for a excisional biopsy kind of a treatment.
So Prashant, my take on this is, and I would invite others to view their opinions on it. If you have a small lesion, which is a T1 mid-third cord, where you know that your margins are going and it is not deeply, on your hydrodissection, it's not deeply infiltrative, you may consider a excision biopsy, but then that excision biopsy should be like a laser resection for a known cancer with margins. You cannot just do an excisional biopsy without margins, because that unnecessarily will mar your further margins. You don't know where the patient has undergone the excision biopsy and you don't know which margins to take. So just like we would do for an oral cancer, if you are going to excise it, then excise it with margins. If you are not sure that you'll be able to excise it with margins, a superficial biopsy without going deep into the lamina propria so that there's no scarring should be done. So if you are not going to be the treating surgeon, you are not going to do a laser resection, you are going to refer it on for RT, just take a superficial biopsy and come out. If you are going to be the treating surgeon, then treat it like you would do for a proper cancer with proper margins of at least 1 to 2 millimeters. KK, do you have any other take on it, or do you agree with
I fully agree with what you said.
Yeah, well, very true, madam. And actually, practical solution, what we do, madam, is that actually we post the patient for a surgery, translaser microsurgery. And at that time, we actually assess and see whether it's truly doable with a translaser microsurgery. And if it's not, then we actually just take a biopsy, and then we kind of refer back to the insurance company saying that, the treatment modality is actually radiotherapy because it's not amenable for laser surgery. So it actually solves both the purposes.
It's very essential also to do the pre-operative voice assessment of the patients. So we need to.
Yes, Asim, I was going to ask Karthik questions about that, but I think he has some internet issues.
I think maybe we can discuss about the speech assessment.
In fact, whenever you are considering a preservation of the organ, you have to assess the voice previously. That is a must.
Yes, sir.
I think Nair will agree with me.
Yes, sir, definitely. And pre-operative speech, pre-treatment speech assessment. I
Yes.
would not call it pre-operative speech assessment. I would call it pre-treatment speech assessment.
That is a mandatory. That is very important. Rather,
So-
nowadays, because of the consumer forum and all, we have to do it.
Karthik, are you back?
Karthik is back.
Yes, sir.
Karthik.
So
Now go
Karthik,
for-
we were talking that you did not mention voice assessment or the
Yes, ma'am.
quality of voice assessment.
I-
So
Yes, ma'am.
pre-treatment, do you think it's important to have a formal voice assessment for patients or not?
Yes, ma'am. 100% true. We have to do a formal pre-operative voice evaluation. So for my patient, we had done voice assessment. If you allow me, I would like to show the video clip, ma'am.
Yes, show me. We are not able to hear voice. Voice is better not coming. No sound.
I can play it again, sir.
Nahin, beta, we could not hear.
It's okay, Karthik. I think there are some problems with the internet.
Karthik, you tell me only two things. What assessment you are doing? What are those tests? One I am telling you since beginning, and what is second?
Hello, sir. I'm unable to hear yours. Yes, sir.
One is the phonation time, and what else?
Yes, sir.
Since beginning, I am phonation.
Sir, I would like to do functional assessment of patient's voice quality. So by doing a GRBS.
There are only two tests which we do in the OPD itself. One is the phonation time, other called as loudness.
Yes,
only
sir.
by two simple tests you can judge the quality of the voice.
Sure, sir.
But what you are doing otherwise?
Sir, we have
Or
done
what?
Sir, we have done a perceptual voice analysis. So we have used GRBA scale to determine the quality of patient's voice.
You use the Walkme or doctor's speech. You are using some. You have got a speech therapist there who is doing all this.
Yes, sir. Yes, sir. We have a speech therapist here, speech and swallowing therapist here. So they have done a formal speech assessment for this patient, and they have given the values.
If I come in details, I don't want to waste time because that is none of much concern. What are the level of the? What is the level of the jitter and shimmer? What is the HNA index?
Sir, I would have to go in depth. I'll have to read up about it. Sir.
I agree. My other colleagues must be knowing only two tests. That is a very good. One is the phonation time, other is the loudness. By that, normal phonation time is 13 to 16 seconds. That is not minutes. You can understand?
Yes, sir.
And what we were talking, 1 to 2 minutes is loudness.
Yes, sir.
Okay. So you now proceed.
Yes, sir. So I guess Prashant sir had asked me about chordectomy types. So if I may I proceed with the answer? So it was given by the European Laryngeal Society. So initially they had given 5 types of chordectomy. Later on, 2007, they had revised it. So given by Mark Remakel and colleagues. So initially, so there are 6 types. So type 1 is subepithelial chordectomy. Type 2 is a subligamental chordectomy. Type 3 is a transmuscular chordectomy. Type 4 is a total chordectomy. Type 5 is an extended chordectomy. So it is subclassified into 4 types: 5A, B, C, and D. So 5A is when we are when the resection includes the contralateral cord along with anterior commissure. Type B is when it includes posteriorly the arytenoid. And type C is including the inferior part, that is the subglottic area. Type D would be resection including superior part, that is the ventricle and false chord. Type 6 would be anterior commissurotomy, wherein resection of anterior commissure with anterior parts of bilateral vocal cord is done, which may include subglottic mucosa all the way up to thyroid cartilage, not including thyroid cartilage in the specimen, reaching up to thyroid cartilage.
What is the other option you are offering this patient other than endoscopic laser surgery?
Ma'am, next would be a radiation for the curative intent. Radiation can be other form of treatment for this patient. So in this particular setting, we would like to discuss the options with the patient first. What are the pros and cons of radiations and surgery, duration of surgery, what is the rates of recurrences in both the surgeries, the voice outcomes following surgery and radiation, initial voice outcomes and as well as later voice outcomes. And also I would like, as this patient is a mill worker, so we would also like to take cost into account, and he's a daily wage worker, so so his I mean the treatment duration time also matters in this particular patient.
So what are the
Can you-
advantages of? So go ahead.
No, sorry, KK, go ahead.
Karthik, what are the advantages you see of laser over radiotherapy?
Sir, advantages of laser over radiotherapy in this setting would be number one, laser surgery in certain scenarios can be done on a daycare basis also, or with minimal number of days of admission without requiring much of hospital stay. Second one, so patient will not be requiring, if we have done adequate excision with adequate margins, so patient will not be requiring any adjuvant form of treatment, and patient would require to come to follow up at regular intervals. In radiation, patient would receive minimum of 30 to 35 fractions, which may extend from 5 to 6 weeks, 6 to 7 weeks, and patient will have to come every single day for 5 days a week to radiation OPD, and also there is significant amount of radiation effects that patient might require, and post radiotherapy patient will have to come for follow-up, and during follow-up the evaluation may be difficult in around 15 to 20% of patients who have laryngeal edema. It may mask the presence of any or laryngeal inflammation or cord inflammation, which may be difficult to identify it as a recurrence or a post-RT changes.
Can you think of some other advantage of laser? One very important advantage over radiotherapy.
I'm unable.
Can it be repeated?
Yes, sir, definitely. So with laser surgery, even if there is recurrence following laser surgery, we can discuss the option with the patient and then and do a laser surgery with very minimal morbidity.
Okay, right. And what are the problems with laser?
Sir, problems with laser is, so it is a three, patient factors, tumor factors, and institutional factors, that is doctor and institutional factors come into play. So if there is difficulty in, so in patient factors, we should look at the type of tumor, what the patient has. In this particular patient,
You're
patient
talking
has,
about the decision of going. I'm asking about the difficulties. Agreed, they are like patient and tumor factors.
yes,
But what are the difficulties in a laser surgery?
sir, we may not be able to get adequate exposure when we are doing
So
a
that
laser
is,
surgery.
exposure may be limited.
Yes, sir. And second is, if the anesthetists are not trained, then even there may be not just the anesthetists, if surgeons are
that's not a valid thing.
I can understand. Yes, sir. I mean,
and it may be difficult in a difficult surgical candidate.
Definitely, sir. Difficult in surgical.
Of a laser.
Completely agreed, sir.
So you said 35 days of radiotherapy. Is that really true for this T1 glottis? What is it?
Sir,
What are
30,
the,
sir,
how do you
usually,
treat this patient with radiotherapy?
sir, for this patient, treatment would be a curative intent radiation, wherein a narrow field radiation is given. So usually now intensity modulated radiation is given for this patient in order to reduce the effects. So it has to be given only just medial to bilateral carotid from hyoid to suprasternal notch. So only that particular area is
How many
irradiated.
fractions?
So 30 fractions up to 2 to 2.25 grays are given, sir, for this patient, if it is IMRT.
What are the types of fractionation schedules, and which fractionation schedule will you prefer in this case?
Sir, actually, there are hyperfractionation schedule has been altered fractionation schedules such as hyperfractionation has been tried. So there is one recent paper, I really don't remember the name. So what they have come to so where they have assessed the IMRT, that is conventional fractionation versus altered fractionation. So in that they have come to a conclusion saying that altered fraction on a long, it doesn't have any significance on voice change, and also they say that there is a marginal improvement in overall disease-free survival, but it is not statistically significant.
Karthik, leave alone the studies. What are the usual fractionation schedules, and
Yes,
which
sir.
will be the fractionation schedule that is what will be the best for your T1 glottis patient?
Sir, conventional fractionation or
Conventional fractionation.
Yes, sir.
Which are the different fractionation schedules?
Sir, hyperfractionation can be tried in this
Conventional
setting.
fractionation, and you are telling hyperfractionation. There,
No,
what are
sir.
the other things?
Hypofractionation is there, but I don't know if we can try and see a glottis in this scenario.
Okay, so you have to read about this.
Yes, sir.
For T1 glottis, the best would be hypofractionation. Okay, what do you mean
Sure,
by
sir.
hypofractionation?
So hypofractionation is fractionation where large amount of dose is given in less number of setting. So the number of treatment doses are reduced. Is hypofractionation.
What is conventional fractionation?
So conventional fractionation is fractionation where only one cycle of chemotherapy is given per day with fixed dose. And given
Okay.
5 days a week with 2 days treatment cap.
Okay, so I'll tell you. So conventional fractionation is 2 gray per fraction, usually.
Yes, sir.
30 to 35. Okay.
Yes, sir.
That is conventional. Usually for T1 glottis, you can give hypofractionation. That will give more gray per fraction, usually up to 2.25 or even up to 3 gray per fraction. And then you can reduce the duration, total number of fractions.
Yes, sir.
Okay. It can be even up to like 16, 20, 25 different hypofractionation regimes are available.
Yes, sir.
Okay. I think you may have to read a little more about it.
Sure, I'll read up, sir. Yes, sir. Thank you, sir.
And Karthik, I think we also need to include the swallowing assessment of the patient for all patients of laryngeal cancer.
Yes, sir.
Whether the patient is going for laser surgery or radiotherapy.
Completely right, sir. We would like to do a swallowing assessment for this patient, but I haven't included in this particular patient.
Karthik, in
Yes,
this patient, what do you think when you are comparing two modalities is the best outcome to be measured as a comparator between these two modalities?
Ma'am, number one, the disease-free survival almost has same. So for surgery as well as for radiation, it is almost similar, more than 90%. But we would like to think more in terms of functional outcome for this particular patient. And so with surgery, patient will have changes in voice immediately post-surgery. But there are 4 meta-analysis on this, so which all say with unison that the post at the long-term voice outcomes of both surgery as well as radiation are similar in this particular setting, and early voice changes would be worse in patients who are undergoing surgery.
Okay, so functional outcomes are
yes, ma'am. Functional outcomes are better outcomes to assess.
Any other parameters you would like to assess patients on? If you're doing studies, what are the other parameters you will compare these two groups for? One is voice outcomes. Okay, and what you said, one is disease-free outcomes. Is there
Yes,
any
ma'am.
other parameter they look at?
So there is laryngectomy-free survival, which can be looked into.
So laryngeal preservation rate is what the
Yes, ma'am.
other
Laryngeal
parameters they look at.
preservation. Yes, ma'am.
Okay. When you're talking about voice outcomes,
Yes, ma'am.
what is you said you will do a GRABAR score. Are
Yes,
there
ma'am.
any other methods to assess the voice, especially when I want to compare patients who have undergone RT versus patients who have undergone surgery?
Ma'am, actually, there is CAP5, CAPV voice assessment score that we can use. So both of these two, the problem would be both are subjective outcomes.
Which
it would be
no, what these are physician administered or patient administered scores?
Ma'am, GRBS, I had read that it can be patient administered also, if I'm not mistaken.
Yeah,
So
but
it is
mostly these are physician administered.
physician administered.
What?
Yes, ma'am.
Have you heard of something called VHI?
Yes, ma'am. A voice handicap index can also be used, wherein we can come it is more of an objective index. Exact components of VHI I have forgotten. I'll have to revise it once again. So VHI is also an objective indicator which can be used to assess the voice outcomes.
Any other quality of life measures for patients?
Ma'am, quality of life.
Have you heard of voice-related quality of life?
Voice-related. I might have to go through once quality of life indices with respect to voice.
Yes. So remember, when you are talking about functional outcomes, you have to
Yes,
see the functional outcomes not just by physician administered, not just by objective measures, but always
Yes, ma'am.
functional outcomes have to be assessed by patient-related quality of life outcomes.
Yes, ma'am.
So read up
Yes,
about those.
Yes, ma'am. I'll do that.
Can I ask you one more question? What is the
Sure,
role
ma'am.
of open partial laryngeal surgery in this patient?
Ma'am, in this particular, in this patient, the exposure is good in this patient. We will be able to do a resection transorally. So in this particular patient, there is no role for open partial laryngectomy.
If you did not have a laser setup and you wanted to offer surgery, what open partial laryngeal surgery would you offer this patient?
Ma'am, I would think of doing a vertical partial laryngectomy, which includes all the way from anterior commissure to lateral cord. So anterior two-third up to arytenoid, not involving the arytenoid. So vertical partial laryngectomy.
Contraindications?
Ma'am, contraindications would be patient if the patient is old and patient's performance status is not good. Patient has comorbidities, who cannot tolerate the mild aspiration, which can be present immediate post surgically. So in that particular scenarios, and also tumors extending to contralateral cords, I wouldn't prefer doing a vertical partial.
Okay.
And also definitely subglottic invasion.
Do you have any idea about data comparing open partial laryngeal surgeries versus laser versus RT?
Ma'am, I'll have to revise that once more.
No. Prashant?
I think that was a very good question, ma'am. And another point I would want to mention is that we have data and literature showing that translational microsurgery is better, but you have to also know what is best in your hands. I may not be very well experienced with laser, in which situation it's better I send it over to my radiation oncologist or refer to a surgeon who is well versed with translational microsurgery.
Hello. Thank you, Karthik, for the case presentation.
Thank you, sir.
And I would request
Thank you, sir.
Dr. Anup Raj, Dr. Deepan Nair, and Dr. Krishna Kumar Thankapan sir to give the final comments about Karthik's presentation and to make comments for whatever things that have been missed and what further discussions can take place on this. Dr. Anup Raj, sir. Deepa ma'am.
Yeah, so Karthik, the history part was quite good. You presented that very well. There was clarity in your thought. But when you've come to the management, your management is very one-sided. I will do laser for this patient. So when you're discussing, especially in a case presentation for exam purposes, you need to list out the options. You have to list out and be very algorithmic in your management investigations. So you can't jump directly to a DL scopy. I know you wanted to show the findings much better, but always be very algorithmic in your case presentation. Go systematically, and even in your management, always chalk out all the various options, and then if you then you can choose one and say why you prefer one over the other. Do not directly jump to one management, if especially for a case like early glottic cancer, where both treatment options are.
Yes, ma'am. Sure. Thank you, ma'am.
Yeah, read up some more of the literature. You will have, this all boils down to what the percentage of control is in both arms and what is the benefit, especially in respect to voice and disease-free survival, as well as laryngeal preservation rate. So these percentages, you don't need to know the exact ones, but approximate percentages need to be known. Otherwise, I think you are doing well. You are in second year, so you have a full 1 more year to prepare for your exams. All the best.
Yes, ma'am. Thank you, ma'am.
Thank you, ma'am. So we come to the end of this session. I thank all the faculties, Dr. Akshay for his excellent talk on transoral laser microsurgeries, Dr. Anup Raj sir, Dr. Deepa madam, Dr. Deepa Nair madam, Dr. Prashant Pawar, and Dr. Krishna Kumar Thankapan sir. So our next discussion will be on 10th of March. The topic will be the advanced laryngeal cancers. And on 12th of March, we are holding a CME on oral cancers. So it's a 2-hour CME on imaging in oral cancers, and I welcome you all. So the registration, will share the brochure with you, and the registration link is there. So registration is required for that. And thank you for coming today. Thank you so much.
Thank you. Thank you, Asim. That was very nice.